appreciate the invitation and the opportunity to share this topic with all of you. ROP is a leading cause of blindness in children. The purpose of our work is to identify early lesions, treat them, prevent blindness caused by end-stage ROP and other pediatric retinal disease. We plan to address ROP. However, aside from ROP, what else might you encounter? I will share several stories with you. A baby girl came to us for ROP screening. We noticed something unusual. Upon examining the periphery, we found vitreous opacity with possible retinal lesions and asked the parents to return in 4 weeks. The vessels appeared normal, but the retinal mass grew and became solid. It was retinoblastoma, RB, and we have a specialized team to handle RB cases. She was transferred to our RB team. We should never miss this kind of lesion. Another case involved a 2-month-old premature girl transferred to us for ROP stage 4 to 5. This was her initial visit to our hospital. She had stage 5 ROP in the right eye and stage 4A with vitreous hemorrhage in the left eye. Due to the vascular activity, we performed a subretinal injection of Lucentis in the right eye and an intravitreal injection of Lucentis in the left eye. This is about our surgical technique of subretinal injection of Lucentis. 3 days after the injection, the vascular activity regressed. We performed laser therapy on the left eye, followed by lens stereo vitrectomy for the vitreous hemorrhage and the tractional retinal detachment. After the vitrectomy, the retinal traction was removed. However, there was something in the macula. Fungus infection was initially suspected, but antifungal therapy was ineffective as the lesion continued to grow. Given the diagnostic dilemma, a fine needle aspiration biopsy was performed with indicated RB. The tumor shrank after chemotherapy, and the retina remained stable without tumor recurrence after 9 years. RB and other tumors can hide in ROP. Always keep tumors in mind. Never miss them. Another case involved a 2-month-old boy who came to ROP treatment. He was diagnosed with ROP zone 2, stage 3, plus positive in the left eye, while the right eye was normal. Laser treatment was administered to the left eye. 1 week after the laser treatment, we observed a ridge, laser spots, and subretinal exudation. The situation worsened 2 weeks after the laser treatment, and he was transferred to our clinic. During his first visit to our clinic, the right eye was indeed normal. However, the left eye showed severe bullous exudative retinal detachment with tortuous and dilated vessels. Due to the exudative retinal detachment and abnormal vessels, we performed intravitreal Lucentis treatment first. 2 weeks after the RVR, the subretinal fluid regressed, and the dilated vessels and telangiectasia indicated Coats disease. All of this reminded us of Coats disease. We performed 2-port endo laser and anti-VEGF treatment, which was invented by our team, and the disease was brought under control, with the condition improving. Let's go back to the beginning. This was a premature boy. The initial appearance mimicked stage 3 ROP. However, the lesions in both eyes were extremely asymmetric. The retinal lesion seemed more like a ridge of vascular tufts rather than typical neovascular proliferation. The subsequent exudation, subretinal hard exudates, abnormal retinal vessels, and non-perfusion areas revealed the underlying diagnosis of Coats disease. Coats disease can occur before the expected date of confinement and mimic ROP, which requires additional treatment and attention. This 3-month-old premature girl was diagnosed with ROP zone 2 stage 3 plus positive and treated with RVR in both eyes. the retinovascular activity regressed 1 month after RVR. We observed peripheral abnormal vessels and persistent avascular retina in the right eye, and retinal detachment adhered to the lens with VH. The bilateral lesions were severely asymmetrical. However, ROP tends to be symmetric. However, the situation got worse in the left eye with vascular occlusions, retinal ischemia, vitreous hemorrhage, and tractional retinal detachment were noted. Bilateral lesions were severely asymmetrical. We conducted a systemic physical examination of the baby and found skin lesions. Upon examining the parents' fundus and skin, we discovered a positive family history. This was actually a case of incontinentia pigmenti. These photos show typical skin lesions of the disease. 1/3 of IIP patients have ocular involvement, most of which are vitreoretinal lesions and usually asymmetric. There are various manifestations of IP-associated retinopathy, which can also mimic ROP. Another case involved a 1-month-old premature boy, born at 34 weeks gestation with a birth weight of 2,250 grams. He was diagnosed with ROP stage 5 or AROP in another hospital. We observed severe retinal dysplasia and retinal detachment in the posterior pole. We arranged FFA for the parents. The mother exhibited fever manifestations, and genetic analysis revealed NDP mutation inherited from the mother. Fever may also masquerade as ROP. In atypical ROP cases, think twice, and fever can hide in atypical ROP. Check the parents, think hereditary in every unexplained vitreoretinopathy. The last case concerned mismanagement. A 2-month-old boy with a small gestational age and a low birth weight was initially diagnosed with ROP zone 1, stage 1, 3+ positive in another hospital. 2 weeks later, at PMA 39 week plus 1 day, the disease progressed to stage 2, 3+ positive. Another 2 weeks later, at PMA 41 week, we observed extraretinal proliferations, neovascularization, and tractional retinal detachment in the right eye. Despite this, the parents were advised to wait and return a week later. 1 week later, they finally noticed the RD and NV and planned to treat it with anti-VEGF therapy the next day. However, the traction worsened on the day of RVR. After the injection, the baby was transferred to us. 6 days after the RVR, the boy arrived at our hospital. The situation was heart-wrenching. We performed laser treatment on both eyes. Along with lensectomy combined with vitrectomy on the right eye, and simultaneous FFA and supplementary laser treatment on the left eye. The FFA revealed fever features. After our treatment, the situation was brought under control. What if the treatment had been given at this early stage instead of the later phase? We believe the baby would have had a different outcome. Timely treatment is crucial. For beginners, never hesitate or feel ashamed to transfer the baby when you are unsure about the disease. You are still saving the baby. Last but not least, every disease you can encounter in full-term babies may also be encountered during ROP screening. To summarize, we should carefully examine the retina, including the peripheral retina, and never miss tumors. We need to identify the underlying disease masquerading as ROP, think hereditary in every unexplained vitreoretinopathy, and make the right choice for treatment or referral. Remember, you can encounter every disease during ROP screen. Let's work together to combat childhood blindness and create a brighter future. Thank our pediatric retina team for the work we have done together. Thanks for the kind invitation and thanks for your attention.